Welcome to the Health is Number One podcast. I'm your host, Dr. Craig Wax, local family physician. We're talking about what seems to be on everybody's mind nowadays, what's going on with coronavirus COVID-19 as it evolves. It is mid-July, and we've got some updates from some specialists treating it in the field. Our special guests are Dr. Vladimir Zelenko, who's a family physician in New York, who is becoming famous and sometimes infamous for the Zelenko protocol on hydroxychloroquine, zinc, and azithromycin. Welcome, Dr. Zelenko.
Thank you, Dr. Wax. Thank you so much for having me.
Sure. And our other special guest today from California is Dr. Richard Fleming, who is also known as the godfather of inflammation, who's a physicist and nuclear cardiologist. Welcome, Dr. Fleming.
My pleasure to be here. Thank you for inviting me.
Well, thank you, gentlemen. It should be a rather rousing discussion with all that's going on in the world. You know, we're fighting a pandemic, and there's a lot of difficult things that come about with coronavirus. It's very infective, but it's more inflammatory than, say, influenza or what have you, but spreads like the common cold. So it's certainly of concern because people that are older or with established disease, or as we like to call them, inflammatory conditions, high levels of inflammation, tend to get a worse case of the disease and are technically at risk. So Dr. Zelenko, can you update us a little bit about what's going on with hydroxychloroquine, zinc, and azithromycin with regard to your protocol? Because there have been multiple problems. We're working on studies, and studies have been flawed. They haven't included zinc, or they've included high doses of hydroxychloroquine, whereas actually a low dose seems to be the optimal way to do it. And people have to be treated in the early stages of disease, which some governors won't allow.
Right. So first of all, thanks again for having me. We just published the study. It's available on preprints.org while it's being peer reviewed. And the study is exactly what you described. It's the use of zinc, low dose hydroxychloroquine, and azithromycin. And our data shows that if you risk stratify patients and basically cherry pick the high-risk patients, which according to my criteria were patients over the age of 60 with mild symptoms, or less than the age of 60 with mild symptoms and comorbidities such as immunosuppression or diabetes, hypertension, heart disease, or anyone that looked toxic, which I describe as either short of breath or just don't have a good feeling about. So those patients were given medication immediately, and that's very important here. Even before confirmatory testing, I would treat these patients preferably within the first 5 days of the onset of symptoms. And the rationale for that is very simple, that the first 5 days with the onset of symptoms, the viral load remains relatively constant. But around day 6, it just explodes like a wildfire. So on average, patients come to the primary care doctor setting between day 4 and 5. And that's simply because the first few days, patients think it's a cold, it's going to get better. On day 3, when they realize it's not getting better, they call the doctor's office. They're most likely to get an appointment a day or 2 later. So when patients on average come between day 4 and 5, it's the ideal opportunity to intervene immediately. And I use zinc and hydroxychloroquine and azithromycin to do that. Now, the problem was that most people advocate for waiting until you have confirmatory testing. But that's, by way of analogy, let's say you have a small fire and you call the fire department and they tell you, we're going to come in 3 days. You know, by then there's nothing to save. So the same problem here, because at least in the outpatient setting, for now, it takes at least 3 days to get the results. I think if a clinician suspects that a patient has the infection, they should initiate treatment empirically immediately, and then adjust the treatment based on the results.
With that said, Dr. Zelenko, if I can mention, it's been tradition in medicine to intervene as early as possible when you can identify the pathogen. And testing can take a while. It can take days to even a week while all the, like your wildfire discussion is going on. And in addition to that, that there's damage ongoing from inflammation while all that's going on. And the testing's not that reliable, whether it's PCR testing, which is the nasal or throat swab, versus the antibody testing, which can test for former cases.
Right. So, in my opinion, the most sensitive tool that a physician has is his clinical sense. You know, it's really easy, in my opinion, to diagnose COVID-19. First of all, it's easy to differentiate between the flu, because you can do a rapid flu test if you're concerned and get a result. But also, it's not flu season, and also very few things present with a rapid sudden loss of smell and taste. And if you have exposure, this virus is 4 or 5 times as contagious as the flu. So if a patient comes and tells me, you know, I had recent exposure, I have a cough and cold, or I lost my taste or smell or whatever, and I do it, let's say a flu test, which I usually don't do actually, and it comes back negative, it's a no-brainer that that's what the patient has. Much more helpful and beneficial to patients if a physician is allowed to use his clinical judgment.
Right, and for the last several hundred years of medical developments, it's always been a physician's prerogative to use their eyes, their ears, their brains, the history from the patient to assemble it into a puzzle that makes sense, and then pull the trigger, if you will, on a treatment when a preponderance of the evidence is present. And we don't usually use testing to do that. Dr. Fleming, what are your thoughts on the inflammatory process and what Dr. Zelenko is presenting?
Well, before I get to that part, I want to address something that you both mentioned, which is clinician response and treatment of patients. It doesn't matter whether we're talking about COVID-19 patients or we're talking about a little child brought into the emergency room that looks like they have meningitis, where we initiate the antibiotics for the coverage of what we believe the infection most likely is based upon the data that we have about what's going on in that population group, or whether we're talking about an oncology, a cancer patient who's become febrile, whose elevated temperature suggests an infection, and we begin treating with the appropriate or most appropriate antibiotics then and there while waiting for the test results to come back so we can then fine-tune our treatment. This is no different scenario for COVID when you're looking at somebody that clinically looks like they have COVID, knowing the sequence of what's going to happen, knowing what appears to be the right medications to treat. We should begin our treatment based upon our clinical expertise. That's why we went to medical school to learn these things so that we could do the best job of taking care of our patients. And from that perspective, for us to hold back on treatment of COVID-19 patients when we know the consequences, particularly in the group of people who have these inflammatory diseases, I would consider that in and of itself not treating a form of medical malpractice. And for anybody to suggest to clinicians that they should not treat patients under that scenario raises serious ethical questions about the individuals telling people not to treat those patients, particularly when they're closely monitoring those individuals. The specific issue of inflammation, which is in fact part of what tees off this response, we know that the vast majority of people will acquire COVID-19. They're going to do that. I'm not convinced at all right now that what we are seeing with the numbers of people testing positive for COVID represents anything but the normal pattern of a virus being spread through the population. Currently, the story, the party line seems to be, my goodness, we've done a terrible job and we have this devastating virus going through the population because we're not all wearing masks, we're not social distancing, we haven't shut down enough. There's no data to suggest that what we're seeing right now is anything but what is normal of a respiratory virus. number one. Number two, we know that the response to this virus for the vast majority of people is well controlled and well handled by people. Whether it's 95 or 99% is moot. It does not matter. The significant thing is that the vast majority of people have an immune response that is functioning normally. It's neither too naive, so it doesn't know how to rein itself in, and it's not too hyperactivated as with obesity and heart disease and diabetes and cancer, all the hyper-inflammatory disease processes that I've talked about since 1994. So for excluding those two groups, we're going to see people respond to the virus. Their immune response is going to bring it under control. But the percentages now that are on these two extremes, because they don't have an immune system that knows when to rein itself in, is the release of inflammatory cytokines, chemicals designed to respond to this infection. One of the very first consequences that we see in humans clinically is a difficulty breathing or being able to get oxygen, because they are now breathing under that inflammatory fluid building up in their lungs. And to tell any clinician that he or she should not be treating these patients with drugs that have been shown to decrease the inflammatory response and to decrease the reproduction or the ability of this virus to reproduce itself and spread further, I think that that is tantamount to it's medical malpractice. But
Yeah,
because
it's unethical.
most of the people telling us this aren't physicians, it's not only unethical, I think it's borderline criminal, because when you get down to it, it is loosely fitted. It's manslaughter. It is the unintentional death of a human being. And if you're not a clinician practicing medicine, and you've never practiced medicine, or you're not responsible for these patients, just because you got an office somewhere doesn't mean that you should be telling doctors how to practice.
Yeah, Dr. Fleming, you make some really good points there, and I certainly appreciate those. You know, you want to reduce the inflammation with all that you've got, whether you've got 100% proof or you're absent testing. You know, certainly physicians have to be physicians, and it's very individualized. That is to say, a physician may suggest 3 possibilities, and the patient may choose the one they want, or they may choose not to do anything. And it certainly needs to be a physician-patient interaction that makes that determination. I think you also made a very good point when you're talking about when everybody turns on the TV news and they're seeing, you know, cases. Well, cases just means positive testing. It doesn't necessarily mean active disease or moderate disease, serious disease, or God forbid, deaths. It doesn't speak to any of that. It just talks about us for the first time here in America testing more than we've ever tested for any infectious illness in the past, seeing the actual natural course of a virus which spreads through the population like wildfire. And it's potentially scary in thinking that it affects so many people. But if you think about it, millions recover and unfortunately thousands pass. What are your thoughts, Dr. Zelenko?
The only thing I disagree with Dr. Fleming is that he said it's borderline criminal. I would remove the word borderline. And I actually think at this point it's not manslaughter, because it's not unintentional, because the information is out there, and our politicians are refusing or turning a blind eye to it because it may support the president, or it goes contrary to the interests of big pharma, which according to my data, if you treat the patients early, it doesn't progress to that severe inflammatory condition where we need to use, we have to rely on the hydroxychloroquine anti-inflammatory effect in addition with steroids and anticoagulation. I think that if you treat the patient early enough, it won't progress to that state. And that's very important. But so there's 3 stages here. There's the outpatient stage, there's the stage 1, then the stage 2, where the patient is either needs to go to the hospital or close to going to the hospital, and stage 3 when they're in the ICU. So if it progresses to stage 2, either because the patient presented too late or for whatever reason they didn't get better with early intervention, or they didn't get early intervention, then it's very important to address the inflammatory component, because it's really 2 diseases. While it's in the upper airway, it's still essentially an infectious process. But as it goes down, then the real hell begins, and the catastrophic inflammatory damage to the lungs and to the circulatory system, the coagulation system. So it's imperative, and this knowledge is out there. This is not anecdotal. You know, anecdote means joke. I don't think it's a joke. My data shows an 84% reduction in hospitalization if you treat early. My patients had a 99.3% survival rate. I'm talking about 2,200 patients. Anyway,
Okay, so let's ask a question, Dr. Zelenko, and I don't know if it's a question for you or Dr. Fleming, but what about herd immunity? Because now we're seeing just how widespread a virus can be, and generally is. It's just this is the first time we've ever seen the entire breadth of it. What are your thoughts on herd immunity and, you know, treating early versus observation, because they might get better anyway? What's your thought of differentiating that?
Well, part of my protocol is exactly that. You have to identify the high-risk patients and treat the high-risk patients. I don't treat the low-risk patients. Low risk meaning less than the age of 60 with no comorbidities, because the statistics are that they're going to get better without treatment. But if you look who's in the hospital, who has the 5 to 10% mortality rate, it's the patients older than the age of 60, or those patients with comorbidities. So those patients need to be treated immediately. I don't know if I answered your question, but.
Yeah, no, that was very good. And Dr. Fleming, what are your thoughts on that and herd immunity? Who's going to get better anyway versus who should be treated with these medications, and when?
Right, and the reality is we don't really have data on herd immunity on this virus, do we? So it's always nice for people to use that as a distraction talking point when they're trying to confuse the general population. Dr. Zelenko is on target when he says we need to treat the ones that are actually having the inflammothrombotic consequences. And as you can see, you know, from behind me, we have our method for FMTVDM of actually measuring the tissue changes and the 4 critical steps that need to be looked at for the treatment of this virus. And the first one is the virus infecting people, and is it able to replicate people? To which Dr. Zelenko has published a considerable amount of data, as have the people at Henry Ford Hospital and some other individuals throughout the world, looking at the ability of the drugs that are available to interfere with the replication of the virus, including, as I've mentioned before, azithromycin. You know, this drug is usually used, people think, to prevent secondary bacterial infections. But if you look at the medical literature, the research that has been done, azithromycin has been used to successfully treat Zika virus, where it has been demonstrated to interfere with the replication of the virus and to improve the viability and replication or continued growth of the glial cells in individuals that were studied. So the theories that antibiotics like azithromycin and the other macrolide antibiotics that we use can only work in bacteria and won't work in human cells is debunked by that research. And so the combined use of that with hydroxychloroquine has reason to demonstrate from Zika virus, which the WHO still says there's no cure for. So I'm not sure how valid we can depend upon them for what they're saying. But, you know, above and beyond that initial phase, then we look at the secondary phases of oxygenation and how to treat patients and how to not cause more inflammation by incorrect use of ventilator settings. And then we have to realize that the immune response kicked in immediately. But by the time several days have passed, the initial cytotoxic component with the release of the chemicals from our cells communicating to other cells to let us know that we need to respond to this infection. Interleukin 6 is the classic one, but there are others. And then the latter 7 to 10 days humoral antibody response, those all have to be taken into account. You know that my preference is, particularly in the hospitalized setting, to use FMTVDM to actually measure results. But I would say that just because the patient gets put on hydroxychloroquine and azithromycin or some other combination and zinc and ends up in the hospital does not mean that those drugs failed, because you never know whether they would have been worse to begin with or not. What you know is that the problem is continuing and perhaps getting worse. So the way that we've structured it is to begin these drugs in the protocol, and then to add to them the additional drugs that are necessary. And to use the example I started with earlier with the cancer patients, when I trained as an intern, my first year as an intern, and I was on my oncology ward rotation, I lost 3 cancer patients, and I felt devastatingly bad about those 3, but that was a record low. And when people ask me why so few of my cancer patients died, it wasn't because of me, it was because of the oncologist who trained me. And he said, Fleming, when these cancer patients come in and they become febrile and you don't know what the infection is, they have cancer and they will die. You begin with these 2 antibiotics, period. And if 36 hours later they have not improved, you will add this antibiotic, period. And if 36 hours later they have not improved, you will add this antifungal, period. And if 36 hours after that they have not improved, you will add this antiviral, period. That's why those people survived, because I didn't have the luxury, and neither did they, to wait for a test to come back to confirm. We did it based upon what kills those patients. And what kills COVID patients is not so much the virus as the response to the virus and this inflammatory response that is to be expected and normally is in balance because we're dealing with healthy people. But with the naive, the immune naive, the very young, or the immune deficient, or with those who have all these chronic diseases where they are already geared up for a hyper-inflammatory response, they are the ones that will suffer. And waiting days is not an option.
Thank you, Dr. Fleming. I
You're
appreciate that. That definitely impassioned and brilliant speech. Thank you. I wonder, Dr. Zelenko, maybe you can tell us, you had said that you tend not to treat young people and people without that severe an illness unless they have what we call comorbid conditions, or they're older, or they're more at risk, which seems to make sense as we're learning the natural course of this virus. Can you tell us a little bit about the possibility of the use of hydroxychloroquine for prevention or disease mitigation like they're doing in India?
Yeah, so I have actually experience with that as well. Let me just explain to you what my emphasis has been up to this point, which was to prevent people from dying, to prevent people from getting on a respirator, and to keep them out of the hospital. And that was my main focus. I didn't really so much focus on the patients that were going to get better anyway, but that's not to minimize their suffering and their 2 weeks of misery. So there may be a very significant role in the use of hydroxychloroquine and zinc and maybe quercetin instead of hydroxychloroquine, but in that early setting as well, in order to reduce the severity of the patient's symptoms, which has value as well. It's just that I can't report on that because that hasn't been my emphasis. And I hope some colleagues will start to study that aspect and see if it's beneficial.
Certainly. Well, there are some current thoughts that even hydroxychloroquine 200 milligrams once a week or every other week, sort of like a malaria dose or an or prevention of malaria dose, I should say, to be more accurate, that perhaps that will be enough to either prevent a patient who's exposed from getting the illness or get very ill from the illness. Maybe Dr. Fleming, you can weigh in on that too.
Well, you know me as a scientist, my final statement on that will always be, we don't know unless we're measuring it. and so I would only be speculating. I think that if we are just doing it to try to prevent people from picking it up, a once a week dose, I'm not sure that that would have the effect because of how long the drug lasts. But I think that Dr. Zelenko gets to the major issue, which is that unless these people are symptomatic, or have comorbidities that would put them at increased risk, he's allowing them to develop their natural immune response unless they need something more, and then they're going to let him know. Is that, I mean, a fair statement?
100%. I have some actual data on prophylaxis, which I think may be very insightful. It hasn't been published yet, but I've actually prophylaxed over 100 people, mostly with hydroxychloroquine and zinc, some with quercetin and zinc. And I myself am prophylaxing myself because I'm immunocompromised. I'm on chemo. I only have one lung. And I actually practice clinical medicine with a good exposure, a good viral load exposure, and without a mask. And I take hydroxychloroquine and zinc every day. Now, that's for myself. But what I recommend for the average patient who is high risk, and I want to prophylax, I do it just the following way. I give them hydroxychloroquine, 200 milligrams, and zinc sulfate, actually, 220 milligrams, which gives you 50 milligrams of elemental zinc. I give them as a loading dose, each once a day for 5 days. And afterwards, I use the once a week dosing because, as you know, the half-life of hydroxychloroquine in the blood is 50 days. Now, let me give you, this is anecdotal, but it's a very interesting case. I had a family of 9 people. I had the husband, the wife, 6 children, and a son-in-law. The husband was a very, very sick man with advanced Crohn's and heart disease. I was very concerned for him that if he would get COVID, he would not do well. So I started prophylaxing him with hydroxychloroquine and zinc, and him alone. A few weeks afterwards, the entire family got sick, except him. He had no symptoms. And then 3 weeks later, I did IgG antibody testing on all of them. And they all were positive with very high titers. His titers were 0. Now, again, this is anecdotal, but this has some potential real clinical implications. Because if the prophylaxis is so effective, it may prevent the development of an immune response. And if and when we ever have a good vaccine, the implications is that these people need to be prophylaxed indefinitely, maybe let's say once a week with hydroxychloroquine and zinc. Otherwise, they remain vulnerable. But that's an interesting case. But in the majority of patients, I've only had one patient who I prophylaxed who got COVID-19, and that was a physician who was taking quercetin every day with zinc, and he had a very mild course. He was in his 60s, very mild course, and he recovered fully. But the rest of the patients didn't even develop it. So that's my answer. I think there's a real role for it, but the question is, do we let someone develop it a little bit and then treat them or prophylax them? I think it depends on the risk of the patient. For example, in the nursing home setting, I would prophylax everyone because I don't want them to develop immunity because they're going to die anyway if they get it. So
right, and we certainly know with 5 or 6 governors mandating that nursing homes and long-term care facilities take sick patients with COVID against their objections when they weren't prepared to isolate them and be able to understand the natural course of this and prevent spread, I think was tantamount to, forgive me for saying, manslaughter in that case. And unfortunately, had we prophylaxed or at least better understood the positive role for hydroxychloroquine and zinc, I think we could have done a much better job and prevented thousands and thousands of elderly losses in this country.
Well, and I want to interject with the nursing home thing, something that's important here in the Los Angeles area. One of the findings that's going on in the nursing homes here is that they have now segregated the elderly into their rooms. They have nothing to do. They're not getting up socializing. They are confined. They are sitting in their chairs or laying in their beds all day long. And the people in these nursing homes are stunned with something that they haven't seen for a long time. Bed sores, decubiti, because the people are in a position stationary for long periods of time, and elderly deconditioned patients that are now falling and injuring themselves because their mobility has been restrained because they're being locked down into their own private rooms.
I imagine their rate of dementia also goes up at that point, and their cardiovascular risk, because they're primarily stationary and they're not stimulated any longer.
We have taken a disease and flipped it on its end. We have taken an infectious disease, and instead of practicing the medical model where we only tested the people that we thought had the disease and only quarantined the people that were infectious, we have decided to do a McDonald's version of testing and pan culture the population, and we have no idea. We've never done this before. As I mentioned earlier, I think that this is the normal transmission of a respiratory virus that we are seeing. And congratulations, in 2020, we decided to pan culture as many people as possible. And we don't know what to do with that data except to be afraid. And we've decided to quarantine the healthy people and decondition everybody, placing, I think, everybody at increased risk. And I really do not like the ads that are coming out now where they are trying to guilt trip people by saying, well, you may be okay, but you might spread it to a friend who will be okay, but that friend might spread it to Grandpa Jones or Grandma Jones who's getting breast cancer chemotherapy, or to the child down the road, and you're going to be responsible for their death. When you're guilt tripping people like that, you have to ask the question just how valid an argument these people have, because when you have to manipulate people and play these stunts with them, you don't have a solid scientific background piece of data to make your statement on, because science,
you know, Dr. Fleming, that's great information, and that's something that's pretty serious, and I think something that we're all quite concerned about with all the government lockdowns and things that have been counterproductive, not just to the development and spread of the virus, but to people's health in general. I think they're very valid points that should be echoed in the highest chambers of this land, certainly, not just medical ones, but other ones as well, because you point to the potential for malfunctional social engineering and political play that unfortunately has taken our elevated science and human bonding and caring to an all-time low. Dr. Zelenko, your final thoughts?
So there's a lot of unintended collateral damage from our response. I can't fault the initial response. We didn't know anything, and I think we needed to be hyper cautious. But as information started coming out, we needed to adjust our approach in proportion to the data. And so what's happened is that, let me tell you the real pandemic right now. It's called child abuse, spousal abuse, suicide, or the amount of people dying from preventable routine illnesses that they wouldn't have died from if they had access to care, but they don't have the access to care because of the reduced resources or capacity to get that care. So there's been a tremendous amount of unintended, or at this point intended, collateral damage that has not been fully assessed and won't be fully assessed for a few more years. So I think that our response at this point is killing more people than the actual virus. I think that we need to reopen society, schools, reintegrate, and the subset of patients are going to inevitably get the infection. We need to treat aggressively or prophylax aggressively or do both, and we'll be just fine. Because if you treat this infection in an appropriate way, it becomes no different than any other infection and that we've dealt with as a world. Now, if you don't treat it—
Thank you for bringing us back to planet Earth on that, Dr. Zelenko. Dr. Fleming, what are your final thoughts?
Well, my final thoughts are that this is a virus like every other respiratory virus that is going to be spread from one person to another person. We have demonstrated that we can flatten the curve and decrease the number of people going into a hospital. We've also demonstrated that flattening the curve does not stop the transmission of this disease, and it's going to continue. We know that the people that are critically at risk for dying with COVID-19 are either the very young that are immune naive or individuals who have comorbid hyperinflammatory conditions, and they need to be treated. And we can't just treat it from the point of view of we have a virus. We have to respond to the fact that we have to treat the inflammation and the blood clotting going on with it. We should, I believe, measure it. And I've mentioned this before, that the patent is available for use for free while the pandemic is going on, so that we can address and target each individual being treated and find their treatment in a matter of days instead of weeks or months, and delaying and causing more harm to these individuals. We have information that shows us that we can treat in the outpatient setting, that the drugs that we are using, that Dr. Zelenko is using, that Henry Ford Hospital is using, that people in Paris are using, that I think they're using it in India, have demonstrated successful reductions in hospitalizations and problems by treating the individuals who are symptomatic, allowing clinicians to practice medicine instead of allowing politicians and elected officials to practice medicine.
No, I appreciate that. So it sounds like we're all in agreement that we should move away from government lockdowns, cookie cutter treatment, and solutions that don't work, more toward educating the public, educating the legislators, and moving toward a better understanding, sensible prevention, early treatment, and protecting those at risk. Is that a fair statement, gentlemen?
I would agree.
Absolutely.
Yes.
No more death by politics.
Okay. Sounds like a good plan. I think we should let physicians be physicians and allow patients the choices of what their preventions and treatments are, and move away from the political and money, big business driven version of medicine.
You know, I want to go ahead.
I'm sorry. I'd rather be anecdotally alive than academically dead.
Okay.
And the final thing I would like to say is that if the people that are running a lot of these stories about what we should be afraid of and what we shouldn't be afraid of, we're really interested in getting to the bottom of this, I think we've had enough sick patients and enough dead patients with COVID-19 that we could have very clearly done the studies to measure the effects of these drugs. And we wouldn't be sitting here having this interview in July of 2020. We would have had answers back in April or May of 2020. And I think that speaks to potentially vested interests that might not be in the best general population's perspective.
Vested interests and political malfeasance, I think, is probably the phrase of the day. So thank you, gentlemen, for sharing your experience, your training, and your care for humankind. And keep working, keep plodding on, keep getting the message out, because it's hugely important in a better, rational approach to the treatment of disease. Thank you.
Well, thank you for the program that allows us to get this information out. Without people like you, we wouldn't be able to get the word out.
Agreed. Thank you, Dr. X.
Thank you again. This has been another riveting edition of the Health is Number One video podcast. We'll be back next time with another edition with professional clinicians discussing what matters to you, your health. Thank you, and we'll catch you next time. Here's your Dr. Wax fist bump.
Thank you for having me.
For this and more information, you can go to healthisnumber1.com. You can also Twitter with us at the @ Dr. Craig Wax, DrCraigWax, and the same at Instagram and on Facebook as well.